Hello everyone, and thank you for spending your day with us. I'm Dr. Belen, and I was tasked to discuss stroke telemedicine, in particular, the use of telemedicine in intravenous thrombolysis. The concept which I'm going to present to you is a relatively old concept, but we use this concept to provide a contemporary solution to current issue facing stroke care in the Philippines, especially when it comes to thrombolytic treatment. Stroke is considered to be the second leading cause of morbidity in the Philippines. The incidence of stroke in the Philippines is increasing, and this is attributed to the developing economy and the dramatic changes in the modern lifestyle of Filipinos. We consider stroke as a neurological emergency, wherein every minute counts. To date, intravenous tissue plasminogen activator is the only approved medication by the Food and Drug Administration for acute ischemic stroke within the first 3 to 4.5 hours of ictus. However, IVPPA is currently underutilized with only about 3 to 4% of eligible AIS patients receiving this treatment. This figure is much lower in the Philippines because of two reasons. One is availability, and the second reason is high cost. But now that IVPPA is included in the updated Philippine National Drug Formulary, the drug is now available and widely distributed at selected government hospitals and is accessible to any patients who are eligible for the treatment. So we now have the patients, the facilities, the drug, and the physicians, but the main question remains, are our physicians confident enough to administer the said treatment, given that not all physicians have experience giving such? Well, the challenge to the Stroke Society of the Philippines is to come up with a program which will not only help improve the utilization rate of IVPPA, but will also ensure its proper use based on the current standards of care and guidelines. It should be feasible and viable. It should be easy to implement. It should adapt to treatment changes. It should be available anytime and anywhere. Should be low cost and should adhere to standards of stroke care. Secretary Duque of the Department of Health recently signed Administrative Order 2020-059, or the National Policy Framework on the Prevention, Control, and Management of Acute Stroke in the Philippines, or simply the National Stroke Policy, with provisions for telemedicine to augment health human resources in the absence or lack of a neurologist or stroke specialist in the healthcare facility. I'm not an information technology specialist. I'm just an advocate of rational use of social media for medical advancement purposes, and I don't have any personal social media accounts except for messaging applications. So just to review, stroke telemedicine is a real-time audiovisual conferencing system allowing stroke specialists to remotely access patients with a healthcare provider and to review their history, physical and neurological findings, their imaging and investigational results across the network. So basically what we intend to do is to bridge this gap of geographical and healthcare personal barriers and improve stroke outcomes by giving appropriate treatment to the right patient at the right time. So this technology could facilitate remote cerebrovascular specialty consults from virtually any location within minutes of attempted contact, adding greater expertise to the care of any individual patient. So this is the SSP Assist PH, which stands for Stroke Society of the Philippines Alternative Support System for Ischemic Stroke Thrombolysis. This prototype was drafted in 2016 and was presented during the SSP and PNA annual convention during that time. It was such a promising project, but it was temporarily put on hold due to logistical issues and most importantly, data privacy concerns. At the time, most healthcare practitioners are not yet comfortable using technology in healthcare, but with the current COVID-19 pandemic, more and more healthcare practitioners are using telemedicine, and it's slowly becoming second nature to us. So this is the initial draft of the second version of the program, but we would like to present this to you as part of CPOS to serve as your guide, just in case you want to establish your own stroke telemedicine network. Once this program is considered final, then we are going to inform you regarding the policies and procedures and the implementing rules and guidelines. SSPSS-PH program is a pilot program designed to make use of available technology in order to provide 24 hours a day, 7 days a week specialist assistance to any physician who is in need of real-time guidance for acute ischemic stroke thrombolytic treatment anywhere in the Philippines. So this will require a high-speed internet connection, a problem which is gradually being improved in our country, a telestroke card, or alternatively a smartphone or tablet, and the needed software for audio-video conferencing. So this is the ideal and recommended setup, but this will entail thousands, if not millions, of monetary investments, not to mention technical training, among other things. But in this program, we will make use of everyday practical technology available through the use of smartphones and tablets with the following installed free software, including Viber, which we will be using as the main channel and the main software for the audio and video conferencing sessions, Chrome for web browsing and access to Google services if needed, Adobe for the portable document reader, but any PDF reader may be used, and the microdicom for neuroimaging review, just in case your neurologist wants to review the dicom images. If not, the images is sent through Viber, and as I mentioned, the main channel is Viber. So it's not HIPAA compliant yet, but it has end-to-end encryption technology to safeguard the data of our patients. So generally what happens with SSPSS-PH pathway is this. A patient arrives at the ER and is assessed by the ER physician. If eligible for thrombolytic treatment, we'll proceed with using the AIS thrombolytic pathway. Diagnostics will be done including laboratories and plain cranial CT scan. The ER physician may call the SSPSS-PH moderator for guidance, of which a decision support provider, of which a stroke specialist or a neurologist will be called to assist. The data will be reviewed by the decision support provider, and the case discussed through audio-video conferencing if needed. The patient will also be examined real-time by the group through the same channel, and the IV PPA will be given. All throughout this process, the patient bedside referrer at the local site will be assisted. And at the end of the consultation, the patient bedside referrer and the decision support provider will be asked to answer a post-consultation survey for feedback and will do follow-up evaluations if warranted. So let us take a look at this hypothetical case for demonstration. So the names of the different personalities were altered for demonstration purposes except for my name to minimize confusion, since you can see that that is my picture over there. So Mr. Juan de la Cruz is a 55-year-old male brought to the ER with sudden onset left-sided upper and lower limb weakness 1 hour after ictus. He was attended by Dr. Largosa, the ER physician, who identified Mr. de la Cruz as having an acute ischemic stroke and is a potential candidate for thrombolytic therapy. The hospital, ABC Public Hospital, happens to be one of the recipients of the free vials of RTPA. Unfortunately, Dr. Largosa has no actual experience in IVTPA administration, but she was able to attend the SSPC post-training workshop for intravenous thrombolysis. So she used the acute ischemic stroke thrombolysis pathway as recommended by SSP and had the initial laboratory workup and cranial CT scan done. And after the process, Mr. de la Cruz was determined to be eligible for intravenous thrombolysis. Knowing that she needs guidance for the thrombolytic treatment, Dr. Largosa decided to connect with SSP Assist PH. She logs in at Viber using her personal account and sends a private message to the SSP Assist PH moderator. Dr. Cheska De Leon is hypothetically the current SSP Assist PH moderator, and she introduces herself and asks for relevant details and asks Dr. Largosa about the specifics for the call for assistance. Dr. De Leon instructs Dr. Largosa to send digital copies of the field thrombolysis form, informed consent, and cranial CT scan images. At this time, Dr. De Leon reviews the sent digital copies of the forms and images to make sure that all forms were properly filled. Dr. De Leon and Dr. Darbosa will go through the form and quickly but systematically verify the information including eligibility, laboratory results, and NIH assess. The patient may be evaluated by Dr. De Leon through the audio and video conferencing. After this process and making sure that Mr. De La Cruz is indeed an eligible patient, Dr. De Leon then calls a decision support provider or the neurologist or stroke specialist on call. Dr. De Leon sends a message to Dr. Belen and relays the request for assistance from Dr. Darbosa. After Dr. Belen confirms that he is available to provide assistance, Dr. De Leon will provide the relevant details, especially the real-time post-ictus, to see how much time is left before the 3 to 4.5 hour limit. The moderator informs Dr. Belen that the documents are available for review. While Dr. Belen reviews the documents, Dr. De Leon calculates the IVTPA dose which will be given. While Dr. Belen is reviewing the documents, Dr. De Leon, the moderator, informs Dr. Darbosa that Dr. Belen will be assisting them. In the event that no specialist is available, Dr. De Leon will provide the assistance. But for the time being, the dose of RTPA is verified. Dr. Belen introduces himself to Dr. Darbosa and Dr. De Leon prepares the group for audio-video conferencing. The audio-video conferencing of the group is now on. The cranial CT scan images of Mr. De La Cruz will be reviewed. But this group review of the images may be omitted if others have no concerns about the neuroimaging findings. Dr. Darbosa introduces her patient, and Dr. De Leon and Dr. Belen examine the patient in real time. Again, this portion may be omitted if the participants have no other clarifications regarding the patient's neurological status. Mr. Ariel Samson, the ER nurse at the local site, is assisted in the preparation of the IVTPA. Instructions regarding the bonus dose and the remaining dose are given. Mr. De La Cruz is then brought to the ASU or the ICU or in any location dedicated for monitoring of post-IV RTPA patients, while the staff are given post-IV RTPA instructions. Dr. De Leon concludes the call for assistance and informs Dr. Darbosa about the post-consultation survey, which she will answer online, and also informs her that she will be coordinating regarding Mr. De La Cruz monitoring at the first, third, and 6 months post-IV RTPA. Dr. Darbosa and Dr. Belen answer the online evaluation, and the responses are updated in real time for review. The follow-up of Mr. De La Cruz at 24 hours after post-IV RTPA will be done by Dr. De Leon. If there are other concerns, Dr. Belen may also be called to provide further assistance. And you can see there that our patient and our patient bedside referrer, Dr. Darbosa, seem very satisfied with how the assistance was provided to them. Of course, some of you might be wondering, why do we have to follow this process when I just can call my neuro friend for assistance? Well, you can always do that, but please bear in mind that we now have the National Stroke Policy in place, and we need to follow certain processes and documentations to ensure that the program is being monitored. Now, this is such a promising program, and just like any other program, a review of the processes and outcomes is very critical. Like clinical teams within the network, we utilize the SSP-SPH program will meet with the program director and participants at quarterly intervals to review all cases treated through the Stroke Telemedicine Network and to review the results of the program evaluation survey as well. The main objectives are to review the processes and pathways at the local site and revise or update the pathways if indicated, and also to review the consultation procedure and revise or update the same. The quarterly meeting will be done through the SSP-SPH Viber channel for convenience. The patient's data will be collected and their outcomes reviewed, which will also serve as raw data which may be utilized for future research studies with the improvement of the program and its application as the primary goal. but it will also be part of the National Stroke Registry, which is also one of the provisions in the National Stroke Policy. Of course, we need to consider legal issues and liabilities. The patient bedside referrer and the local medical team are responsible for the patient's continuing care and for any acts of commissions or omissions. The decision support provider is responsible for any advice given during the remote consultation. However, it is understood and implied between the two sides that the recommendations given by the decision support provider are based on the current protocols and the guidelines for thrombolytic treatment of acute ischemic stroke. Such recommendations are given with the best interest of the patient in mind and may or may not be considered or followed by the patient bedside referrer or attending physicians at the local sites depending on their own assessment or decision. In the future, we would like to have one application with cross-platform compatibility to serve our goals and our mission of providing excellent care for all Filipinos at any time and anywhere they may be. But this entails a lot of planning and review, but we are getting there, especially now that the National Stroke Policy is in place. We already have the concept and we will be working hand in hand with the national government, in particular the Department of Health, because change is coming and we are very much ready to adapt to these different changes. So this is an ideal stroke telemedicine setup, but as I said, this will entail millions of investment. This is an alternative stroke telemedicine setup and these are already widely available for anyone to use. Practically everyone has a smartphone with mobile internet capability. This is how a stroke telemedicine looks like. You have good-looking doctors, good-looking nursing staff with heavy stroke telemedicine equipment working perfectly for them. A doctor may do her rounds walking side by side with the telestroke cart, which is worth millions. But this is how we apply stroke telemedicine in our own acute stroke unit. Well, we still have the good-looking doctors and good-looking nursing staff, and we have our own equipment. But do you see me in the picture? Well, there you go. But if we have funds to spend a large amount of money for the telestroke carts, we would. But we don't have that much. What we have is our own stroke cart, which we use at our acute stroke unit, if needed. It may not be the most ideal, but it's working efficiently and perfectly for us. At the end of the day, it's not about the equipment or the software, which will make a stroke program successful, but the brains and the hearts of those who make the stroke program work. And these are those people. And with this slide, I would like to thank everyone for listening and enjoy the rest of the day.